So let's talk about the current billing process. As you know, providers submit billing information to the state. You have 365 days to do that. And you report each of the hands-on attendant care bundle services, meaning if you are providing personal care for that Elder Choices client and homemaker and adult companion, you are having to bill separately for each of those services in 15-minute increments. So the issues with that is that it does create a huge administrative burden for providers, as you know, those are similar services, and yet you're having to report them separately using the 15-minute increment. So this shows what the current system is and also what the new system. Currently, you have 365 days to submit the billing. New system, no changes to that. Current system, you report the hands-on attendant care bundle services separately at 15-minute increments. New system, you can bill at hour-long increments. You can report attendant care services as one bundle, meaning that you don't have to. We won't have the individual homemaker, adult companion, personal care. It will just be attendant care services. And you can report the total amount of care provided to the client over a time period up to a month, and you may really want to consider that. And I'm going to say again, this new system is not in place right now. It is our plan, and it has to go through the regular process of approval by CMS, promulgation, and review by public health, et cetera, et cetera. And when we get to that point of promulgating the specific policies, it will be out there, and we will be wanting your comments as you review the policies. Benefits of the new billing process for clients and providers. Clients will receive their hand-on attendant care services in a more seamless manner. Providers will experience less administrative burden in their interactions with the state, and you'll have flexibility to tailor the hands-on attendant care services based on the client need. And this relates to the payment improvement initiative tenet of rewarding providers for high quality, efficient care. Okay, so this is an example of how we see this working. That again, the current system, right now, if you're providing adult companion, you are billing in 15-minute increments. And with the new process, you would actually bill 4 hours. So, 16, 15-minute increments, old system in August, new would be 4 hours. In-home respite, current billing system is, an example would be 8 15-minute increments in August over 5 days. The new system would be 2 hours in August. And then provider payment, which I know everybody's going to sit up and listen. Okay, this is the current rate. I'm just going to say one more thing before I'm going to go back to this one more thing. Because a point I want to make about there are other services and Elder Choices that are currently in 15-minute increments. That's adult daycare and adult day health care, and we're moving forward too with doing that in hour increments also. Again, subject to approval. Okay, provider payments. Currently, providers are reimbursed $16.70 per hour for homemaker, personal care, attendant care, adult companion, and in-home respite. Providers are reimbursed $7.68 per hour for adult daycare. Providers are reimbursed at various rates for adult family home, chore service, in-facility respite, home-delivered meals, assisted living, and PERS. The issues with the current provider payment, there have not been any rate changes since 2009, and your costs have increased significantly in that time period. So we went forward with getting provider stakeholder group involved in looking at rates. Current system, as I said, is $16.76 per hour for homemaker, personal care, attendant care, adult companion, and in-home respite. The proposed rate increase for attendant care bundle, personal care, non-waiver, and in-home respite is at $18 per hour. Again, that is going to be subject to the legislative review and budget approval. And again, we are looking for this to be implemented July 1st, 2015. Again, provided we can get the legislative approval for that in the Medicaid budget. Adult daycare, the reimbursement rate is $7.68 per hour. The new system increases, well, we're increasing it to $10 an hour, again, subject to legislative review and approval, budgetary approval. And then the other provider services that we have, adult family home, chore, in-facility respite, home-delivered meals, assisted living, and PERS, those are currently under review. So the benefits for these different provider payments for the clients and the providers. For the client will not experience any changes in their interactions with the HCBS system. Providers will receive higher reimbursement rates for the attendant care bundle, in-home respite, personal care, and adult daycare. Providers will be measured on quality going forward. And this relates to the Payment Improvement Initiative tenet of reward providers for high-quality, efficient care. And now I'm turning it over to Krista.
Implementation plan. As Connie said, we have internally discussed this. We have internal alignment on the requests that we would like to make, and we have added those to the budget request for Medicaid. We anticipate, if approved, that this will go into effect 2015, as she said. Same thing with utilizing the RUGs and the extenuating circumstances on the plan of care process that we are looking to do. We have been, the folks that work with the data, we've been gathering and looking at data now for a while, and we anticipate that starting in July. July kind of is our rollout date for some of these changes. And so this is, I was going to say this is October. I always think a few weeks ahead. So none of this stuff is actually approved or, at this point. We're working on the documents that will do that. So I want you to understand that while we have had a work group with certain providers helping us on this, this is the point in time where we are actively engaging everyone now to provide us feedback, because it is not too late. This is not, we're not just like spoon feeding you, this is how it's going to be. What we're saying is this is the best effort, goal to keep a manageable work group going, to work in the best interest of all provider groups and all of our consumers, to put the best thing forward as a working plan. And now is the time that we're actively, please, I want you to work with us on giving us your feedback from your perspective, if this seems reasonable, if there's any gaping holes that we have missed, anything like that, because it is not too late to circle back around. The unused portion, the 20% rollover, all of that we're looking at, we are looking at a July rollout, mainly because all of our documents will have to be updated, our waiver documents, state plan documents, and so they have to have an effective date, and we are thinking that this gives us enough lead time to work with that. Because those all required kind of some policy decisions, and we had to get to a certain point. Now we're at the point where we kind of have those decisions. We can always incorporate, we will always refine over time, and we can bring anything else in. But we had to get some critical thoughts out there and checked off. So now that we kind of feel like we have those decision points, we have working groups internally to our offices that are designed to look at policy, how we will incorporate all of this into our policy manuals, our IT requirements. John had mentioned everyone it seems like IT is just the big thing, and systems change, as you know, is huge, especially in something as large as DHS. And, I mean, it is for y'all as well. Anything you do is a big deal. So we're working on that. And then, of course, we do realize that training is number one. We have to train our nurses. We have to train providers and make sure everyone is comfortable with the new culture and the new way that we're going to do our business, and because all that will obviously have a direct and bottom very hard hit to our consumers and our clients, and we want it to be as smooth as possible. And if there's one thing, we have learned, it is to give that time we need to make sure everyone is trained and that things are working properly in order to roll it out. One of the things, a lot of what we just said deals directly with providers. We looked for ways to increase flexibility, to give providers, put them more in the driver's seat in terms of the actual care delivery, to reduce the administrative burden. All of that actually, it kind of does help the providers out, but the bottom line with that is anything we do to help the providers is ultimately going to push back down and be better for our consumers. Our consumers won't have as many people coming in and out of their homes, and the break of services, just the hard break of things like that we had in the past won't be occurring. It will be much more seamless for our consumers, and their experience will be greatly enhanced. I can't stress enough to you that I'm very concerned with the care coordination aspect of this. I want something much more robust than what we're currently able to have under just our regular targeted state plan with the three components that are allowed under that. And we want to make that easier as well. That, again, you have to bill in 15-minute increments, and it's administratively very difficult, and I think a lot of providers don't bill for things that they do feel are critical to care, but they don't feel like Medicaid will reimburse. And so we need to look at that and figure out a way as how do we get the comprehensive view, and not just a provider view, not just protecting your area, making sure things are going well within your own shop, but how we're connecting the medical component and the larger view of that client, whether they want to have gainful employment, and all the network that works with all of these different areas, education, all of these areas, and how we make sure we are being very effective with that. We want to have accountability for that, targeted case management right now, and I'll put this on the state. I just don't know that there's accountability out there for what is going on, and that's shame on me. And so I want to make sure that if we empower these agencies and we're entrusting and we're releasing some of what we feel we're obligated to kind of keep close to our chest, and we're releasing that, and we're all in agreement that it should be at the local provider level, that there is accountability back to us so that we are ensuring that the health, safety, and welfare of our clients is in fact out there. Quality metrics, you heard reference to that, and again, it just kind of goes back to accountability. If we're going to allow a lot more flexibility, if we're going to really push the tenets of improving the quality of experience and the quality of health, that our folks are healthier and that kind of thing, we need to reward the providers. But we also need to make sure that we measure to that and make sure that we are seeing that the shift in the health status or whatever metrics that we're looking for. And so we are currently working on that. That is a work in progress, and we will be communicating that back with you. We are happy to receive any thoughts on the matter, and we will have a dialogue on it. Here are some examples that we are looking to potentially start with. And let me just say that I think the first year or so we are actually just going to be benchmarking on this. And so whatever we kind of land on, it will be a test period for us where we will actually just work with providers, give data back, let you know what we're seeing. And because for one thing we have to figure out, is that the right area for us to be looking at? And so some of this is just going to be working through. But one of the adherence, you'll see that box there. We have a quality assurance process right now with DHS, and we look to see we look to see how close the plans, how close we're hitting the mark. Right now we're looking at that. That's how we were able to come up with the examples for the current system, how many hours are actually authorized on the plan of care versus how many were utilized on those two examples that you saw. We can track that very easily. And what we see across the board, I think in all of our waivers, that is the number one deficiency currently, is that we are not hitting anywhere near our targets on what the plan of care says. Well, that's a problem for us. It's a problem for me to think that if someone needs this many hours, they're not getting it. So what is this meaning for this particular client? So you will see adherence to the plan of care. If we're going to go down to a primary provider that's charged with providing the personal attendance services for a client, we want to make sure if they need weekend hours, they're getting weekend. If they need that, they're getting that. And we just want to make sure we're watching the adherence to the plan of care. Health-related metrics. This will require much more conversation in terms of what we're measuring through the MDS home care instrument, the certain areas on that. We might look at utilization of health care, medical care things such as emergent care utilization. I'm going to say we're early in that conversation, and that's going to be a longer range thing. Institutionalization, we might want to look at exactly that, the rate of institutionalization. Critical incidences, allegations of abuse, exploitation, neglect, that type of thing. And then client satisfaction, and we've had a conversation about this, and you can laundry list the pros and the cons for asking someone if they're satisfied with services. Someone who has a bad attitude isn't going to be satisfied with anything, right? And should that really impact on scoring or whatever with regard to providers? But I will just say this, is there has to be a meaningful way to engage our consumers in asking them to share with us their experiences and how they have been. And so while all of our divisions, as I mentioned before, the big three, long-term care ones, which is developmental disabilities, behavioral health, and our division, HCBS, we're all kind of going in different paths toward payment improvement. Just based on the way our networks are designed, based on the way our care delivery has been historically designed. But there are some areas that need to be, looked at potentially in a common, through a common lens, and that might be one in terms of client satisfaction. So we actually are looking at bringing in some consultative services for someone who has specialized in our long-term populations and how to actually truly glean out from them, meaningful information that can help us on this particular area. I do know that in developmental disabilities, for example, they have had for years what has been called the National Core Indicator Survey. That is a direct interview survey. And while we have chosen to not use that, in the Aging Network, for example, our national association has some states that are working on adding questions specifically to that that are more germane to our population. And we may or may not in the future move to that, saying that we're looking at that, and that I think it's an important part of all the information that we will be asking for. So understanding that what we've tried to do here today is talk to you all about some of the changes that will be coming. I always want to tie it back to one of the fundamental challenges for our population, for our services and our network, is getting people to the services that they need as quickly as possible. And I spoke earlier about presumptive eligibility, and if it takes us 2-3 months to get someone processed through their application process, we know a lot can happen. And we know generally that people come knocking on our door when they need services today or yesterday. They don't need them. They're not pre-planning forward, 2 to 3 months. And it's absolutely critical that we respond faster, and we just have to. You might know that our division assumed right now we're in a kind of a test phase for taking the financial eligibility roles of the department for long-term care and bringing them under our umbrella. The goal for that is to work together with the medical eligibility and the financial eligibility to make sure we coordinate all those processes and that we move them as quickly as possible. We want to get to have one screen. Right now we have multiple data systems that run in a siloed manner for the different types of different processes for eligibility. And if we can get those all blended to one and we can get that communication going better between the two sides of the house, then we feel like we can speed that up. That said, long-term care is the most complex application period in Medicaid, and it just takes a while because of the assets, identifying assets and working through all of that. So we want to have some kind of screen that we can do through our providers, even through potentially in the future the consumer himself, and go through a series of very short questions to help identify those that do need the assistance, that do look like they will be deemed eligible, both financially and medically. We are running a screen. It's called the ABLE, A-B-L-E, and that stands for the Arkansas Brief Likely Eligible. It's just a series of, I don't know, it's less than 10 questions, I believe. And we have run those with people who have applied for Medicaid services. And so we're waiting now on the medical and the financial decision points to match right back up to the questions to determine in what percentage we can accurately predict eligibility. And from there, that will let us know as a state what the liability would be for the state in saying, yes, we will go ahead and use state general revenues to pay for people to start services before we actually have stamped them officially as eligible. And so that's a work in progress. We hope we have Holly Felix in the House, and College of Public Health is working with us to finish that analysis up, and so we hope to be able to work through that in another, I don't know, a couple of months or so. Certainly by the end of October, we hope to be able to bring that to Director Seelig for us to know whether or not we can move forward with that. Next steps. Here you have kind of just a very, very brief outline of the activities and timing. So we will be working, as I said, on the quality metrics over the next couple of months, 2-3 months. We will be looking to refine and finalize the care coordination in that same time period. Presumptive eligibility, as I said, hopefully by November. The payment model we're working, that's going to take a little bit more time because that systems changes and that kind of thing. Now, let me just say, as I have said earlier, everything that we have talked about today, with changing the 15-minute increments, with changing all the separate services under one bundle, all of that requires approval by CMS and by our legislative review process. And so we are moving into that process now where we will be writing up these changes. Again, that's why I do encourage you, email us, call us if from today you have questions or you want to raise an issue that has not been thought of by your work group representatives, and we will be happy to visit on that. And anything like that can happen over time, but we are looking at starting this. Now, some of you might have heard phrases such as Community First Choice as a program or an initiative of this state or of the department in working in conjunction with our payment improvement. And we are working on that. And there's been articles in the paper. There have been things on television, I think, with the news here lately with some efforts from some groups to get support for Community First Choice. Now, as a provider, you might have gotten notice that a manual or a policy manual went out on Consumer First Choice and that we were scheduled for a public meeting on that this particular Friday. And then we put an ad in the paper. I want to announce for everybody to hear me that meeting has been canceled. Okay, for right now, that meeting is canceled. We are currently working with CMS on a weekly basis with phone calls and to go over our proposal or what we are thinking, how it will work here in the state. And CMS has posed some questions to us right now that we have to take a step back and try to answer. And primarily it has to do with the differences between our divisions of developmental disabilities and our division on payment mechanics, because their payment improvement is going down a bit different path. And so how they are planning on paying and how they are planning on bundling, for example, it's just different from us because of the way their provider base is developed and how it has operated traditionally. And so what we have to do is try to answer the questions to CMS about those differences and how that will ultimately affect the consumers to make sure that there is consistent and fair treatment of our clients throughout whatever division that they happen to come through the door on. And so because of that, we know there will be changes to that manual, and instead of having a public hearing Friday and then making changes and have another one, we just decided to wait until we have more accurate information blended between the two of us. So we will have additional forums such as this between now and July. We will have training dates that will go out to you all with instructions on how to participate in that. That's all I know on that page right now. I can't stress enough that this is all projections at this point. And so when you go back, you'll still have to bill next week on your 15-minute increments and that kind of thing, you know. But we're hoping that that is exciting to you to think that there might be a day where you are not buried in the, you know, the weeds of that kind of, you know, inflexible nature. So please take this as an opportunity and an invitation to get much more engaged than you have been if you have not been. Here you have the website. You can ask questions. We're fixing to open it up for questions. If you don't want to ask, I know there's so many times when I don't want to ask a question because I feel like, oh, this is the most stupid question ever. Trust me when I say we've asked a lot of questions, and there are no stupid questions. So ask them. If you're not comfortable with that here, then write them down and submit them through this, or email me directly, or Connie or Stephanie, and it's our name, you know, with a dot in the middle, krista.hughes@dhs.arkansas.gov, and then of course theirs is the same with their name.